Do we have treatments for delirium, or is it just a matter of stopping all the other treatment?
The numbers of pharmacotherapies are probably disappointingly low. So I'll talk about them first, and then I'll talk about non-pharmacological therapies. When we first started to understand about delirium, we thought it was a neurotransmitter problem. So we searched among our dopamine antagonist agents, which of course are the antipsychotics. And they are used still very commonly in the acute sector to treat delirium. Sadly, the evidence for these therapies is lacking. For delirium, when I mean delirium, I mean the syndrome of delirium, which causes the cognitive decline. There will be patients who have delirium who become very agitated for the antipsychotics, including haloperidol, quetiapine, olanzapine, will have some effect in reducing the agitation, but they will not affect the delirium syndrome. There are other therapies like benzodiazepines, which again we think cause harm in delirium, but if someone is acutely agitated in the very short term, they may help the agitation, but it's long-term infusions in the ICU, we try and avoid them. Opioids, again, can cause delirium. And in terms of treatment, actually the only group of drugs that have been shown to have any evidence of benefit, I guess, are the alpha-2 agonists. And the two drugs that we know in ICU or related circles is clonidine, of course, it's originally antihypertensive, now used in chronic pain and agitation and delirium in the ICU, and dexmedetomidine. There's actually quite reasonable evidence that dexmedetomidine will treat and prevent delirium. What is disappointing for us in ICU is that evidence was really assessed in patients that were not severely unwell, if that makes sense. It was in patients who were quite severely unwell, and they used the dexmedetomidine to prevent them getting worse, if that makes sense. But there is still evidence it has effect. Clonidine, there's weaker evidence, and in fact I'm involved in a study called A to B, where we are comparing dexmedetomidine versus clonidine versus standard care. And one of our secondary outcomes is delirium prevention.
So a brain that is already compromised is obviously not going to do well if you hurl more insults at it.
Christy, you said it, in fact, it's the vulnerable brain. We think, although I have to say, we do get delirium in children as well. And that's probably because they're so unwell. Whether we get the same cognitive decline is yet to be established.
You started this answer with pharmacological treatments. Do you also have a comment on non-pharmacological treatments?
That's a very good question. There are a number of non-pharmacological therapies which have been shown to reduce delirium. None of them, as far as I'm aware, prevent the subsequent cognitive decline, which is a real pity. But they include early mobilization. So that's why you'll see patients in ICU, critical care, hip replacements, because there's a lot of delirium in these patients. Getting them out of bed as early as possible reduces the delirium burden. Stimulation, cognitive stimulation, so talking to the patients, interaction with relatives, next to kin, orientation in time and place, and really, very importantly, is this sleep-wake cycle. In fact, one of the things in ICU we're not particularly good at is keeping our patients in our sleep-wake cycle, because when they're acutely unwell, we give them infusions of sedatives and opioids, and that completely destroys it, of course. So when they wake up, they're completely disorientated. And when we get them back into a normal regime, the delirium prevalence reduces. As I said, sadly, this does not have any effect yet on the later cognitive disturbance.
So can the sleep-wake cycle not be re-established just by darkening the room at night?
Very good question, if only. I think it's probably quite part of the answer, in that many patients when they're acutely unwell are not treated in a single room. And we're not able to darken the room because they require observations that have to be undertaken every hour. And they're so unwell that we have to, assess them every hour. but darkening the room does help. Interestingly, on that sphere, there's been a ton of studies looking at melatonin in delirium, because instinctively you'd think it would work. But as far as I'm aware, there's no evidence of any benefit. So there is something about darkening the room and keeping the lights off. There's certainly something about these bright, the neon lights, and reducing that, encouraging ordinary daylight, which does help.
And moving on, what impact did COVID-19 have here? I mean, is delirium a feature of late disease?
It's a huge feature in COVID-19, and I believe in older patients who develop COVID, that is one of the main symptoms, is delirium. What we have seen with COVID-19 is a prolonged and severe delirium. Now that's probably, yes, very sad. That's probably slightly related to the course of the virus, in terms of it's quite a long illness, isn't it? I mean, I accept the most recent Omicron was much milder, but severe COVID was a long illness. So we think there are the effects of the virus on the brain, effects of these very small thrombus in the brain, which cause delirium. And there's also neuroinflammation that goes alongside. So yes, it is a big cause of delirium and caused huge problems treating these patients in the ICU. And the latest literature, I believe, is suggesting those with severe COVID, there's about 25% of them who have later cognitive decline, which is dreadfully sad, isn't it? If you're a young patient,
Yes.
I'm not saying patients will never recover. There is some evidence that patients will recover, but there are accountants who can't add up, mathematicians who can't add, people who can't go back to work, people who, no longer pursue a full and independent life. So it's very sad. This brain fog, which is a typical sign of long COVID, isn't it? That, I suspect, this is just my suspicion, is triggered by the acute delirium that patients have had when the disease is worse. And this triggers, we think, an inflammatory process in the brain, which takes some time to resolve.
And is there any research into new or repurposed treatments for delirium?
I'm actually leading a research group exploring the use of intravenous thiamine supplementation in delirium. As everyone will know, thiamine, of course, is vitamin B1, and it's an essential, if we hark back to our biochemistry days, our undergraduate days, thiamine diphosphate is the active form of thiamine, and it's an essential cofactor in a number of the enzyme systems in the brain. And we think our most recent sort of hypothesis is that delirium is triggered by an abnormal glucose metabolism or under glucose metabolism. And we need thiamine in a number of these enzyme systems, including alpha-ketoglutarate and transketolase. And so we think that we have reasonable evidence to suggest that flooding the brain with thiamine in delirium may reduce its prevalence in ICU. What's very encouraging is that thiamine is actually very, very safe. In fact, it's safer than most of the other drugs, as you know. And of course, it's been used in the NHS. Many people will remember it as Pabrinex. We don't convert thiamine to its active form in alcoholism. So of course, it's one of our main treatments in Wernicke's. So we know that it's safe. We think that it's effective. We're just hoping very much to get funding to undertake a small study to prove that it gets into the brain in delirium and reduces the brain network disintegration, which is essentially delirium, and then finally undertake a large site randomized control study to assess the effects of thiamine, IV thiamine versus delirium versus placebo in delirium.